So we'll start with the surgical anatomy of face and neck with the basic principles. So meaning to say that the facial nerve being the queen of the face, we as facelift surgeons have to be the king and protect the nerve throughout the face. So this will be more or less like a storytelling, and facial anatomy is more or less arranged in a layered manner. It's a layered concept where you already know there is from layer 1 to layer 6 various tissues attached with one another, and hence it is more or less like a sandwiched concept where the base is bone and the topmost layer is the skin, with all the structures like the subcutaneous fat, muscle, mass layer, deep fat layers all sandwiched in between. With this little if you look at this toothpick, it acts at, you can say that it is more or less like the retaining ligament that we were talking about yesterday. So it kind of keeps things in place. So surgical anatomy is basically an interplay between the smas, facial spaces and the retaining ligaments. The smas layer to begin with is basically, it was established by Tessier and later further described by Mitz and Perron in the landmark article of 1976. What does the smas really do? It is basically a fibrofatty tissue which is laminating the muscle. And yesterday we were having a talk about the smas layer and we were discussing. It is just like when you buy a shirt from a mall, you see there is a layer of paper in between the folds. So it prevents that wrinkling from happening in the clothes. Smas kind of does something similar. So there is a reticular cutis that connects the dermis with the underlying smas, and hence superiorly you will see it is extending towards the superficial temporoparietal fascia, and downwards it is a connection with the superficial cervical fascia. Its main functional role is the movement for expressions, because unlike the skeletal muscle, it is not connecting bone to bone but bone to the superficial skin, and hence when you smile, certain people do have those dimples coming in because the muscle is pulling in the skin overlying. An exception would be the parotid gland, which is this wherein the smas is very tightly adhered, and if you happen to dissect it into the smas flap, you will see the facial branches lying right underneath the smas. So we have to understand, the moment we go beyond the smas layer, things become like a Pandora's box. You have a lot of nerves, lymphatics, parotid ducts, all of that we have to take into consideration. So as you know, we're not getting into the anatomy of parotid, but as you know, the facial nerve goes into the substance of parotid and it emerges from the anterior border of the nerve, and then it divides into certain layers. So as it goes down, there is a certain space. Now you will repeatedly hear about many facial spaces, right? The preseptal space, the prezygomatic space, the premasseteric space. So what are these spaces? These spaces are basically, you can say, a husband who after 1 year of marriage needs some space. He doesn't want the queen to budge in to that space. So the facial nerve or any important structure doesn't enter to this space. Meaning to say, if you look at the premasseteric space, consider that this is that space, and the upper buccal nerve and the lower branches, they are just cornering the superior and the inferior border of that space. The only thing that budges into this space is some amount of masseteric fat, right? Apart from that, there is nothing much into this space, so particularly a safer zone. But what happens when the nerve goes into the anterior border of masseter? It dives down into the deeper layers, right? So when you're dissecting, the idea is as superficial, you're fine, but once you go into the deep plane facial lifts, you might encounter these nerves. So this is a lifting of the platysma and superficial fascia, and as you remove the superficial fascia, you will encounter the premasseteric space where you see there is mobility. It's not like right? You can see the underlying structures there, right? So now let's talk about the branches, because I would say that the facelift surgeries, it kind of drapes around the facial nerve. So it is like a queen walking through the face, and all the anatomy has been built around the facial nerve. So we have to understand that the various branches that are there on the face, we have to save them during the facelift, because there are certain classical you can say papers written by Furness back in 1965, where he had mentioned the course of the facial nerve trunk, and followed by Pitangui and Ramos, who talked about the trajectory. So out of the 100 cadavers that were dissected by Callender, he found out that 8 of those 100, 8 out of 100s had a very huge variation in its course. So the trajectory remained the same, and we will talk about that in the later slides. So the nerves, they stay deep to the outside of the spaces at all times in the lateral faces. So the spatial anatomy, if you look at, we spoke about that toothpick in the beginning, right? So you can talk about that in the sense that there are certain ligaments which divides these spaces, the spaces which virtually does not have any important structure except that fact. And you would see here, you would see the preseptal space is divided by the orbital retaining ligament, and the prezygomatic space is again divided by the zygomatico-cutaneous ligaments. And hence, you would see all of these spaces have a certain defined spaces, and they are all differentiated from one another by these ligaments. Now, talking about the temporal branch of the facial nerve, it is along the Pitangui line, and it is from a 0.5 centimeter from the tragus and 1.5 centimeter lateral to the eyebrow. So this is basically the danger area. Danger area as in all the areas that you see in yellow. In yellow are areas where you have to be very cautious while you're dissecting. And the areas in red need extreme caution, and that is the marginal mandibular nerve area. So we're not getting into the branches of it. Just to say that the buccal branch rami, they travel within the mid portion of the parotid gland, 2 to 4 centimeter lateral to the anterior border of the masseter. So you have to be very cautious when you reach the anterior border, except in a few cases, 19% of the cases, where it dips down and crosses the anterior facial vessels. And hence you would see the zygomatic branch. You can depict the course around the parotid gland. We are not getting into the details of it because it will be taken later. So we'll be getting into different types of layers. So reaching down to the layer 4, that is the subsmass layer. It is a complex area. You would see that there are soft tissue spaces, which I have already mentioned. And these red retaining ligament is, you can say, the adherence of the ligaments or the smas layer over the muscle. So this is like the palatido-masseteric fascia, which is tightly adherent on the muscle area, right? And then there is the last layer, or you can say the deepest fascia, deepest soft tissue layer of the face. So sometimes when you've done all the layers for facelift, you require a 6th plane, and that is underneath the periosteum or the subperiosteal dissection. So there are various alternative levels for dissection, as you can see, right under the skin. So there will be a skin type, subsmass type. At the muscle, we use the muscle mostly for traction, right? Underneath the subsmass, then subperiosteal. So there are various levels of dissection that we speak about. Then moving on to the surgical anatomy of the neck, you would see there are critical anatomical areas around the neck which are the cervicomental angle, which needs to be somewhere between 90 to 110. Otherwise, it will look like a turkey neck. Then, of course, the submandibular triangles and submental triangles, and the conial angles. So you need to work on the neck contour along with the facial rejuvenation or the facelift surgery. You need to do some amount of neck lifts as well, right? So we need to, the improvement of the neck contour is predicted by the skin release. And of course we spoke about those toothpicks. So you have to release those toothpicks. And there is a notion that over a period of time as we age, there is a laxity of the ligaments. But there is no actual data to support this claim. Mostly what happens is there is an osseous you can say degradation, and there is a resorption of the bone, and hence anything that drapes over a shortened skeleton would sag down, and that is why we have to go in for a level 6 dissection as well. So then of course you have to alter the platysma, and you at certain areas you will see there is a popping out of glands, or you can say the glands, they are just kind of out of their place, so you have to tuck those glands in. So basically, how do you do that? So if in a study by Hüttner, around 65 to 70 millimeter from the gonial angle, if you draw a line, right, that is the point where the mandibulo-osseo-cutaneous ligament exists, and around 5 to 8 millimeters above this ligament, there is the course of facial nerve. So we have to be very cautious when we are dissecting at the lower border, during the lower border correction. Then, of course, the GAN, the greater auricular nerve, being a purely sensory nerve, we have to figure it out by the McKinney's point, which is about 6.5 centimeter inferior to the external auditory meatus. And if you draw a line from this, if you want to mark the danger zone, you have to drop a perpendicular from the lobule, which is 90 degree to the Frankfurt's horizontal plane, and again draw a line which is at a 30 degree from this perpendicular. So under this triangle you will find all the important nerves. So it will give you an understanding as to, you have to keep it extremely safe. Then of course that we talk about the submental fat herniating between these two platysmal muscles. There are various types of variations that you see, and that is the type 1, type 2 and type 3, where there is an interdigitation of the platysmal bands. And you would see that the platysmal muscles, in 75% of the cases, they tend to decussate at 1 to 2 centimeter posterior to the mandibular symphysis. In 15% of the cases, it is from the mandibular symphysis to the thyroid cartilage, and in 10% of the cases, it does not show any decussation. That brings us to another technique, that is the max lift or the minimal axis cranial suspension lift, mostly done for the full face, but in the neck region also you can just use certain you can say fixed structures. You can use the purse string sutures to actually pull in the neck, and that makes the cervicomental angle better. So that would be all from my end. These are my references.
Thank you very much.